Welcome to this explainer. Today, we're doing a clinical masterclass where we'll unpack the absolute complexities of rheumatoid arthritis. We are taking a highly practical, case-based approach tailored specifically for multidisciplinary healthcare professionals. Whether you're a doctor, nurse, physiotherapist, rheumatologist, or anyone in between, you play a totally critical role in managing this chronic, systemic autoimmune disease. Let's get started. Let's kick things off by meeting Sarah. Imagine a 45-year-old patient who just walked into your clinic. Her primary complaints? This gradual, really insidious onset of severe fatigue and bilateral hand pain. But here's the crucial detail. She mentions that her morning stiffness lasts way past her first cup of coffee, often well over an hour. Now, if we aren't sharp, symptoms like these in an otherwise healthy middle-aged adult could so easily be misdiagnosed or just brushed off as simple wear and tear. But as we'll see, the clock is already ticking on her joints. To figure out what's going on with Sarah, we're going to follow a clear roadmap. We'll look at the pathogenesis and global burden, the clinical presentation and assessment, how to navigate the differential diagnoses, the key diagnostics, evidence-based treatments, and finally, long-term management. All right, Section 1, Pathogenesis and Global Burden, the Systemic Threat. Rheumatoid arthritis really isn't a rare condition. It impacts roughly 1% of the entire global population. That might sound like a tiny drop in the bucket, but to put it into perspective, that is a massive, massive number of people dealing with chronic morbidity. We're talking about irreversible disability, immense economic costs from work absenteeism, and a severely reduced quality of life if the disease is left unchecked. This is a systemic inflammatory threat, not just a localized joint problem. So what's actually happening inside Sarah's joints? It's basically a cascading immunopathogenesis. It all kicks off with an environmental trigger, maybe smoking or a mucosal pathogen, in someone who is already genetically susceptible. This sets off enzymes called peptidyl-arginine deaminases, which modify proteins in a process known as citrullination. Suddenly, these proteins look completely foreign to the body. Dendritic cells show them to T cells, B cells start pumping out autoantibodies, and bam, they all rush to the joint synovium. This unleashes an absolute cytokine storm, driven heavily by TNF-alpha, interleukin-6, and IL-1. The synovium swells up into this destructive tissue we call a pannus, which essentially signals osteoclasts to start eating away at the cartilage and bone. It's a relentless cycle. Moving on to Section 2, Clinical Presentation and Assessment, Recognizing the Patterns. Now, the key here is spotting those classic hallmarks of RA early. Sarah's presentation is completely textbook. She's got this symmetrical polyarthritis. And look at the target areas. It typically goes after the small joints of the hands and feet, specifically the MCP and PIP joints. Plus, she's exhausted. That profound fatigue is a massive red flag for systemic inflammation. And that morning stiffness lasting over an hour, that is the dead giveaway. It strictly differentiates inflammatory arthritis from just everyday mechanical wear and tear. Oh, and since this is a systemic disease, we absolutely have to keep an eye out for extra-articular issues, like rheumatoid nodules or interstitial lung disease. To really track Sarah's progress accurately over time, we can't just ask, hey, are you feeling any better today? We need a rock-solid, structured assessment framework. We're talking a detailed history of her functional limits. Can she open a jar? Can she get dressed easily? Then we get hands-on with formal 28 joint counts to document exactly how many are swollen and tender. Finally, we plug all that into formal disease activity scores, like the DES-28. This gives us a concrete, mathematical target to shoot for during treatment. Okay, Section 3, Navigating the Differential Diagnosis, Ruling Out Mimics. It's honestly wild how many conditions can masquerade as early inflammatory arthritis. We've got to quickly and accurately separate RA from osteoarthritis. Remember, OA is your classic mechanical wear and tear disease. It typically goes after the DIP joints and the base of the thumb, the CMC joint, which are areas that RA usually leaves alone. And with OA, that morning stiffness, it's super brief. They loosen up quickly, unlike Sarah, who is struggling for over an hour every single morning. We also have to rule out viral arthritis. Things like parvovirus B19 or rubella can trigger a symmetrical polyarthritis that looks exactly like RA. But here's the catch. A viral infection usually hits fast and hard, maybe with a fever and a history of recent sick contacts, and it's generally self-limiting. Sarah's symptoms, though, they've been creeping up insidiously and have stuck around well past that crucial 6-week threshold, pointing straight toward chronic autoimmunity. Let's head into Section 4, Diagnostics and classification criteria. Confirming the suspicion. So, we need a highly targeted diagnostic workup to confirm what we're thinking. We'll run specific serologies. Rheumatoid factor is helpful, sure, but anti-CCP antibodies, those are the real MVPs here. They're incredibly specific for RA and often warn us of a much more aggressive disease course. We'll also pull acute phase reactants like ESR and CRP to check the overall fire in her system. And baseline imaging is absolutely non-negotiable. Plain X-rays of the hands and feet let us hunt for early periarticular osteopenia or actual established erosions. If the X-rays look clean but our gut says there's active disease, ultrasound or MRI are fantastic for spotting early silent synovitis. We take all of this data and run it through the 2010 ACR/EULAR classification criteria. This is way more than just a diagnostic checklist. It totally structures our clinical thinking. By assigning points based on how many joints are involved, the serology titers, those elevated acute phase reactants, and the fact that her symptoms have dragged on for over 6 weeks, we can definitively classify Sarah's disease. And more importantly, it gives us the solid justification we need to start aggressive therapy. Which brings us to Section 5, Evidence-Based Treatment Strategies, Halting the Damage. Our overarching, totally non-negotiable philosophy here is an aggressive, early treat-to-target strategy. Why this matters is simple. The window of opportunity to stop irreversible joint destruction is terrifyingly narrow. Once that bone is eroded, guys, it is gone for good. Our target is strictly defined. We want sustained clinical remission or, at the absolute least, low disease activity. We roll out our pharmacologic arsenals step by step. For most folks, we jump right into a conventional synthetic DMARD immediately. Methotrexate is our heavy hitter, the anchor drug. But because methotrexate takes weeks to really kick in, we'll often use a short-term corticosteroid bridge to quickly cool down that inflammation, along with NSAIDs just to give her some symptomatic relief. Now, if Sarah doesn't hit our target on methotrexate alone, we don't just sit on our hands. We rapidly escalate to biologic DMARDs, like TNF or IL-6 inhibitors, or we bring in targeted synthetic DMARDs like the JAK inhibitors. But let's be real, pharmacology is only half the battle. A true clinical masterclass requires holistic, multidisciplinary care. We have to get physiotherapy involved to keep Sarah's muscles strong and preserve her physical function. Occupational therapy is an absolute must for joint protection strategies and adaptive tools so she can keep doing her daily tasks independently. And we can't forget structured patient education programs. We need to empower her to self-manage flares, truly understand her medications, and handle the heavy psychological toll of living with a chronic illness. And finally, Section 6, Long-Term Management and Pitfalls, the Lifelong Journey. These powerful medications we're using do carry significant risks, so our drug monitoring has to be flawless. With methotrexate, we're constantly checking liver function, complete blood counts to watch for myelosuppression, and serum creatinine. When we step up to biologics, we have to stay on high alert for opportunistic infections or latent TB waking up, plus regular malignancy screenings. And for JAK inhibitors, we're keeping a very close eye on lipid panels and monitoring for cardiovascular and thromboembolic risks. Beyond the joints and the specific drugs, we've got to manage the big systemic picture. That chronic inflammation is quietly accelerating atherosclerosis behind the scenes, meaning cardiovascular disease is actually a leading cause of mortality in RA patients. We've got to aggressively mitigate those cardiovascular risks. We also need to prevent osteoporosis, make double sure her vaccinations like flu and pneumococcal are totally up to date before suppressing her immune system, and have some really frank conversations about family planning. Methotrexate is highly teratogenic, so strict contraception and careful planning are absolutely crucial if Sarah ever wishes to have children. The rhythm of all this long-term care really comes down to the number 3. Every 3 months, we sit down and evaluate her disease activity using that DAS-28 score. If she hasn't hit that remission target, we adapt, we escalate, we just keep pushing. We absolutely do not accept good enough when her joints are on the line. To wrap up our explainer today, I want to leave you with a provocative clinical challenge to think about. Just imagine this. What if Sarah achieves deep remission for 2 whole years, but then suddenly shows back up in your clinic with subtle symmetrical joint swelling? Are you fully prepared to rapidly differentiate a dangerous RA flare that demands immediate treatment escalation from a benign viral mimic that just needs some supportive care? Protecting her joints completely depends on your ability to answer that question. Thanks for joining me for this masterclass on rheumatoid arthritis. Keep learning and keep asking the right questions in your clinics.